this headset is new to me, but we're kind of intimate. So yeah, if you can't hear me, let me know. I can just try to turn the volume up. Perfect. And thank you so much for having me. This has really been wonderful. This is my first time in Sweden. I've been to Europe many times, but often to the continent and traveled by train and never got the chance to come to Sweden. And I am really enjoying myself so far. The bilingual nature of Swedes here is really wonderful for me, since I really only speak English. But I was in Paris over the summer, also presenting there, and there was a conference like this, and they had translators in the back of the room, and they were translating from English to French, and everyone was wearing headsets in the audience. And that was a really interesting experience to me. And I think a number of my attempts to be funny were lost in translation. So hopefully I won't have that problem today. But if no one laughs at my attempts, I'll know it's me and not the translation. So let's talk a little bit about this. So does anybody here know anything about Alabama? When I say that, does that bring any ideas to mind? I'm curious. For anybody somewhat familiar with the geography of the US? So some of you, yes. So this is in the deep south of the US. So it's in a part of the US that is known especially for a history of racial disparity and income inequality. At one point, Birmingham was the most segregated city in the United States. It was founded after the US Civil War. There were iron ore deposits in Birmingham, and some businessmen realized they could start like a steel company there in Birmingham. But because the Civil War had just ended, they very specifically designed the city to be segregated. They had black workers in one place, they had white workers in another, and the city grew from there. And at one point, like I said, it was the most segregated city in the United States. And Martin Luther King, Otto has a poster of Martin Luther King up in his childhood room, which I've got to sleep in last night, thank you. Martin Luther King chose Birmingham as a site for much of his activity because he knew it's where he would sort of stir up the most trouble, because it was such a segregated city. The people of Birmingham are very proud of that history, but it is still a place that has trouble. And as you'll see, as I talk about some of the work we've been doing, the population there is still living with a lot of disadvantage and a lot of obstacles to flourishing. And I've grown accustomed to living there. It is not an easy place to live. We had a UN representative in this part of the US recently, and he described it as resembling a developing nation, and that is definitely true. And again, Stockholm could not be more different. I'm just I'm amazed at how efficient and clean and beautiful this city is, which of course gives me hope. I think we can pull it off. Birmingham could be like Stockholm one day. It will take some time. So you might think Alabama, it sounds a little backwards. It is a little backwards. How are we doing this work in Alabama? Well, a couple things. First, Humphrey Osmond, does that name ring a bell to some of you? Some of you, yes, okay. So Humphrey Osmond coined this term psychedelic, or psychedelic, which is interesting that the S is added here. But he came up with this term in a letter and correspondence with Aldous Huxley. And Aldous Huxley had had an experience with mescaline with Humphrey Osmond, who was an English psychiatrist. And I can't remember the exact words, but Huxley said something like, to make this mundane world sublime, just take a gram of phanerothym. And I'm not sure what phanerothym meant. It was derived from the Greek. And Humphrey wrote back, because people wrote letters then, no, that's not what we should do. Here it is. To fathom hell or soar angelic, just take a pinch of psychedelic. And psychedelic is from the Greek. It means mind manifesting or mind expanding, which seems to be a pretty accurate description based on now what we know what psilocybin does in the human brain. Humphrey Osmond's last academic home was at the University of Alabama at Birmingham, funny enough. He was there until the late 90s, maybe early 2000s. He worked well up until his late 80s. And he only moved after he had a fall and his wife wanted to leave the hot weather and go to Wisconsin. And when he left some boxes with some colleagues who I've met who live nearby. And in those boxes were all the correspondence between him and Aldous Huxley. So I've met this couple. They have these letters in their garage in a box. And it also includes the little AA book that is inscribed to Humphrey Osmond from Bill Wilson. and they just have that around. It's pretty amazing. I have a picture of it if you're interested at some point. But Alabama has a history. Also, Timothy Leary, I'm sure most of you have heard of Timothy Leary. I'm hoping. He graduated from the University of Alabama, which is different. It's about 45 minutes from Birmingham. But he was initially a student at West Point, and he was expelled just because he was always misbehaving. And he was almost expelled from the University of Alabama for sneaking into the women's dorms. They had separate dorms at the time, but was allowed to finish his degree via correspondence. They wouldn't let him back on campus after World War II. So Alabama has a history, and I should also say that the psilocybe genus grows rather prolifically in the wild in this part of the world. The weather conditions are just right. So the city of Birmingham itself is politically progressive, from the perspective of American politics. It's thought of as a very blue dot in a red sea, if you know what I mean when I say that. And our mayor was handpicked by Bernie Sanders, who's a very well-known progressive, I think self-described socialist politician in the US. But the surrounding area, the redder area, tends to be very libertarian, meaning that the people there would tell me, we like what you're doing because the government has no business telling anybody what they can put in their body. And also, yeah, when I was young, my friends and I would sneak into the cow pastures and pick mushrooms and look up at the stars, and what you're doing makes sense. So I haven't had any political pushback at all. I think everybody seems to be very happy with what I'm doing. And the funny thing is, in the US now, there is wide support for this work from people on both the left and the right. And right now there's a movement where a lot of more conservative politicians are really interested in funding this work, in large part because they've seen the application, especially with MDMA, to veteran populations. And as Otto could tell you, he's an expert in political science. For some reason in the US, those on the right tend to really latch on to the military and veterans and love veterans and anything that could help them. My thought is, whatever the motivation, as long as they're supportive, that's fine. So I think things are moving along. We have some federal funding, and it seems like support across the political spectrum. Let me get into my talk now. See how this goes. Oh, let's see. Okay, there we go. So classic psychedelics, I usually use that term, my preference, to differentiate from other substances that you might call psychedelics, although some people think that the term psychedelic should be reserved for these classic psychedelics. But when I say classic psychedelics, I'm talking about the serotonin 2A agonists. So that would mean MDMA is not part of this discussion, ketamine isn't part of the discussion, salvia divinorum isn't, nor is cannabis, although I could see how one might think of these as psychedelic. Ibogaine, not part of the conversation, but the 2A agonist would be LSD, psilocybin, mescaline, which is found in the peyote cactus and others, and a dimethyltryptamine, or DMT, which seems to be everywhere, though is orally active in ayahuasca. So we know that these agonists are widespread in nature. Like I said, DMT seems to be present in at least trace amounts in almost every plant on the planet. But you'll find psilocybe mushrooms almost everywhere. In this part of the world, liberty caps, as I understand it, grow rather prolifically. Okay, good. Pear's telling me I'm correct. And as far as we can tell, humans have used these substances for a really long time, often for therapeutic purposes. On the left is a reproduction of a cave drawing that was found in modern day Algeria. It's 10 to 20,000 years old. And you can see it's some sort of humanoid with mushrooms growing from its body and mushrooms as hands. And this was found in what is thought to be a temple of sorts, in which mushrooms were likely used as a sacrament or in these sort of healing contexts. And then these other two finds are from modern day Mexico or Central America. Both were associated with the sacramental use of mushrooms. And the interesting thing is, a number of these finds, like this mushroom in the middle, was at first thought to be a representation of the peyote bulb, which has might look like the cap of a mushroom. And most scholars in the 1940s weren't even aware that there were psychoactive mushrooms. That would not have been known. And most scholars thought that these anthropological finds were references to peyote. That was until this gentleman on the right came along. His name was R. Gordon Wasson, and he was a banker and an amateur mycologist from New York. And his wife was a Russian-American pediatrician. And so the story goes, R. Gordon Wasson's wife was quite the mycophile, meaning she really liked mushrooms. She liked foraging for them and eating them. And in their conversation, they started to say, they hypothesized that there were in fact psychoactive mushrooms in modern day Mexico, that these anthropological finds referred to not peyote, but to mushrooms. And they wanted to find where they might still be used. So R. Gordon Wasson started to ask around. He started to go to Mexico and ask, where might I find this still in practice? And he eventually found himself in a very remote village in the state of Oaxaca. And he met this woman you see here whose name was Maria Sabina. Maria Sabina was an indigenous person. She would not have spoken Spanish. She would have spoken only her language. I think it was Mazatec. And R. Gordon Wasson eventually was allowed to participate in one of these ceremonies known as a velada. And Maria Sabina was hesitant, as you might imagine. He was a Westerner, a white man, participating in a ceremony that, as far as we know, a white man had not participated in before. And he was told that he could participate on the condition that he did not reveal her name or location. And he agreed. He participated in the ceremony, and very shortly thereafter, his experiences were documented in this magazine, Life, which was at the time a very popular magazine in North America. You can see at the top, it says, great adventures in the discovery of mushrooms that cause strange visions. And in this publication, he revealed her name and location, even though he said he would not. And this speaks to, in part, the somewhat troubled past here that we have with psychedelics, and how we might approach the use and exploration of these compounds, especially when interacting with indigenous populations in the New World. He also revealed her name and location in a book that he published with his wife. And this led to an influx of tourists, Western tourists. I think in Spanish, they were even known as yippies. So hippies, yippies, that overwhelmed this village. And there was already a fraught relationship between the indigenous people and the police, and made things worse. All these Westerners were heading to Oaxaca, hoping for this experience. And she really regretted having ever introduced him to the velada. But Albert Hofmann, who I'll talk about in a moment, who is known for his discovery of LSD, did at one point accompany R. Gordon Wasson and was able to take one of these mushrooms back and identify psilocybin as the active component in these mushrooms. So the same person who discovered LSD also identified psilocybin as the active component in these mushrooms. He was there, and he gave Maria some of the psilocybin. She tested it herself, and she said, yes, the spirit of the mushroom is here. This will serve as a great substitute when I don't have any mushrooms on hand. A little known fact, Walter, who's interested in this sort of thing, R. Gordon Wasson's research was funded in part by the CIA. Does everyone know who the CIA was? So a spy agency in the US that was very interested in exploring these compounds as weapons, as compounds that could enhance interrogation. I think there was some thought that they could create the so-called Manchurian candidate, that they could control somebody with one of these substances. So they were interested in finding novel compounds, and they, maybe with his knowledge, maybe not, they did fund his travels to Mexico, which is an interesting bit of information. So now LSD, we have Albert Hofmann here on the far left. The story is really fascinating. He was interested in compounds you might find in nature. He thought that there might be something in the ergot fungus that would help with some post-birth complications that some women have in circulation. And he thought there might be something about lysergic acid diethylamide, which is in the ergot fungus, that might be helpful in this regard. He was working with the fungus. He synthesized LSD and then shelved it, thinking it won't be helpful. But at some point later, he thought, I should revisit that compound. And in doing so, it would appear he got some on his fingers and accidentally ingested LSD and had the first experience, unintentional, with LSD, and thought, well, that was really interesting. I should do that again. But this time I'll do it intentionally. And that day is known as Bicycle Day because he was at work, he ingested LSD, he was a little overwhelmed, so he got on his bicycle and went home. But like any good scientist, he tried to describe his experience as best he could until it was overwhelming, but then later continued to document his experience. And LSD, per Hoffman's experience, was thought to be helpful in psychological context. So the first thought was, for Sandoz Laboratories where he worked, we could use this as an aid to psychological therapy, psychoanalytic therapy, and Sandoz Laboratories sent their drug out far and wide, hoping that psychiatrists and psychologists would study this further. And they did. We see Humphrey Osmond here on the right wearing the tie. On the left is one of the most unusual characters in the history of psychedelics, Al Hubbard. We were discussing Al Hubbard last night. Al Hubbard was a high school dropout from the state of Kentucky, which is a rural mountainous state. And he became very skilled at smuggling things into Canada up near Seattle, which is Pacific Northwest. And he was eventually caught and told, we'll be willing to look past what you've done if you help us smuggle aid into the UK from Canada. The US was not officially in World War II yet, but assisting the UK. And he said, I'd be happy to help. And it was at that point that he met members of the OSS, which was the precursor to the CIA. The CIA purchased large amounts of LSD. So as Sandoz was sending out LSD to psychologists and psychiatrists, the CIA was buying as much as it could because the CIA was convinced that the Soviets would put LSD in Americans' drinking supply to maybe convert us to communism, or who knows. It was this thought that you could control someone's mind and make them more suggestible. And the CIA was also convinced that if its agents were captured, they would be, by the Soviets, they would be administered LSD, and therefore every agent was told they had to have had an LSD experience to prepare themselves for that day. So Al Hubbard here would have been exposed to LSD through his friends who became CIA agents, which is very funny. But Al Hubbard, who was a devout Catholic, thought that he was, after this experience, had a mandate from the Virgin Mother to spread the word of psychedelics far and wide. He had what is often called the beatific vision. It was a very religious, spiritual type experience, and he felt, yes, this could change the very nature of humanity, not only in medical settings, not only for psychiatry, but he felt it could sort of revolutionize global consciousness. And maybe many people have had that insight. This could foster in this era of peace and harmony. So he wanted anyone and everyone with some influence to have an experience with LSD. And he went everywhere he could, trying to turn people on, as they would say, to LSD. And he was fairly successful. Humphrey Osmond was one of these people who he contacted. Humphrey at this point was in Canada. And a lot of the work that Humphrey Osmond did is in large part because Al Hubbard introduced him to the drug and had a pretty interesting protocol for administering that drug that we still use today. It involves eye shades and music and making people feel very comfortable. So we still owe a debt to Al Hubbard, which is interesting because, you know, many of us are very educated, overeducated, but Al didn't finish high school. And many of his insights are still applied to this day. You may not be able to read this, but this is one of my favorite oddities, you might say, from that first wave of psychedelic work. I'll read it for you. So Al Hubbard was up in Vancouver, and he met a reverend, an ordained Catholic priest, a Reverend Brown. And he introduced this individual to LSD. Again, he wanted to contact all influential people he could, introduce them to LSD because he really felt this would change the world. So this Reverend Brown was happy to have this experience. And it was so moving to this Reverend that he wrote an open letter to his congregation. I like to read this because many of us think of psychedelics and we think of a counterculture, we think of the hippies. At least in the US, this is the case. But this is evidence that at one point LSD would have been very mainstream. It would have been not out of the ordinary and a representative of a very mainstream Orthodox organization, in this case, the Roman Catholic Church, was openly discussing his experience enthusiastically with his congregation. I think that's another way of seeing psychedelics, and perhaps an argument that their image could be rehabilitated. Not that they have to be thought of as traditional and Orthodox, but they don't necessarily have to be associated with a counterculture, as is often the case. Now, Otto and Walter tell me that in Sweden, that psychedelics are stigmatized, probably very similar to the US. So again, I think this is a bit of evidence that might argue to the contrary. So he wrote, "Friends, true scientific knowledge is the honorable objective of man's inquisitive intellectual faculties." And by the way, this letter is beautifully written, I think. The sciences have divided into myriad sections, the vast, seemingly limitless data that is ours to learn. Over the centuries, man has gained collectively, drawing on his predecessors and sharing with his colleagues and successors. Each division of scientific knowledge has produced proof conclusive of the supreme being responsible for the perfection of order our scientific minds uncover. We are aware of man's fallibility and will be protected in our studies by that understanding and recognition of the first cause of all created things and the laws that govern them. So he's setting everybody up. He's being very cautious. He's being clear here that he is a believer in the scientific process. He then says, we therefore approach the study of these psychedelics and their influence in the mind of man, anxious to discover whatever attributes they possess, respectfully evaluating their proper place in the divine economy. We humbly ask our Heavenly Mother, the Virgin Mary, help of all who call upon her to aid us to know and understand the true qualities of these psychedelics, the full capacities of man's noblest faculties, and according to God's laws, to use them for the benefit of mankind here and in eternity. Very interesting. That is a real letter that was written to a Catholic congregation in 1957. So the question is, what happened? I'm arguing that they had been mainstreamed, that they were not out of the ordinary. There wouldn't have been any association with the counterculture. What in the world happened? I mean, there was tremendous interest in the scientific community. There were over 1,000 clinical studies with 40,000 participants or more. So many, many people had been administered LSD, mostly in clinical trials. And if you look at the older literature, it's very clear that the scientists and clinicians at the time were very excited. And here are just a few examples of some studies from that period of time. LSD was used in criminal settings and criminal justice settings. It's a study in which LSD was evaluated in the treatment of criminal psychopaths. That's what the title reads. This was one of the studies that came from that Humphrey Osmond group. And this was a study on LSD and the treatment of alcohol use disorder. There'll be more on that in just a bit. Here is a study from the Archives of General Psychiatry, which is now JAMA Psychiatry. And this was a study of LSD in the treatment of opioid use disorder. Obviously, the language was not as sensitive then. They say narcotic addict. We wouldn't say that now, but these were people who were addicted to heroin. And JAMA Psychiatry is a very prestigious journal. Many of us would be thrilled to publish there. And this study, which was a very rigorous study, showed a pretty promising effect of LSD in the treatment of opioid use disorder. There was also this publication in the Journal of the American Medical Association. And this was a study by Walter Pankey and others. You'll see Stan Groff, who's a very well-known name in this field. And this was all about the use of LSD in treating end-of-life distress or demoralization. Again, in a mainstream journal. Now, I'm a psychologist. This is the American Psychological Association sort of hallmark journal. And there was a rather long review article about the effects of LSD. So I say all this just to say there was nothing fringe about it then. It was mainstream science, and there was a lot of interest and enthusiasm. Again, the question is what happened. We'll get to that in a moment. This was a very nice meta-analysis that the Norwegian couple, Terry Krebs and Paul Ørjan Johansen, conducted. You all have any contact with them, by the way? They're just one country away. Okay. I haven't heard from them in a while. Anyway, they did a meta-analysis of some of the more rigorous studies that were conducted between 1966 and 1970 targeting alcohol use disorder. And you'll see that there was an odds ratio of almost 2 favoring the LSD intervention over the control condition. So this was a reduction in alcohol misuse with an odds ratio of 2 favoring the LSD treatment over the control condition. So when you find in that older body of research some of the more well-conducted trials, you do see that there was a reason here, it seems, to be enthusiastic about this emerging intervention. But meanwhile, these substances found their way outside of medical settings into uncontrolled contexts. And when I say that, I am not passing judgment on these people. I would generally agree with some of the libertarians in Alabama, where I'd say the government does not have any right to tell people whether or not they can use any drug for that matter. But this use outside of medical context led to some sensationalized media reports of LSD use, mostly LSD use. That and this counterculture that was emerging in the United States at the time probably didn't do any favors for psychedelics, right? They became associated with this counterculture, which would have been pretty radical at the time. Timothy Leary, who was a professor at Harvard, who was brilliant and charismatic, was content to become a sort of public figure rather than a professor. He was fired from Harvard. He liked media attention. He sort of acted like a clown at times, but he was just a extremely charismatic. Many people think of him as like an Irish storyteller or bard in that tradition. He was very entertaining. And I think he enjoyed entertaining. He enjoyed being something of a clown at times. And the perception was that Timothy Leary was encouraging the youth of America to turn on, tune in, and drop out. That was his phrase, encouraging them all to use LSD. And at one point, Richard Nixon, the president of the US at the time, dubbed him the most dangerous man in America, which was silly to think of him in those terms. But the president had said, this man who's trying to get the children to use LSD is the most dangerous man in America. I think we also have to consider at the time that there was likely no frame of reference for men with very long hair or facial hair or colorful, loud clothing for some of the music that had emerged at the time, as well as an entire generation saying, we do not want to go to Vietnam. We do not want to kill our fellow human beings. And, we don't really want to devote our lives to the acquisition of material wealth. So we're just going to sign out of this capitalistic society altogether and go live in the woods on a commune. And I think Nixon was terrified at that idea. And perhaps if everybody had decided to take that course of action, the fabric of society may have disintegrated. I don't know. I turn to this triptych. Does anybody know what this triptych is, by the way? What is it? Yes. Yes, so very good, Gustav. It's Hieronymus Bosch, a late medieval Dutch religious painter. It's called The Garden of Earthly Delights. And I have taken this image from one of my former professors' TED Talks. His name is John Haidt. He has a number of really excellent TED Talks. He used this, John Haidt did, to describe the psychology of politics. Okay, so he'd say, look, in the beginning, things are ordered. They are as they should be. Right? We are calm, we are serene, everything's happy. But in the middle, you'll see the natural order begins to change. There's a little bit of chaos there. And on the far right, we now find ourselves in a dystopia, one in which we might expect to see Batman trying to bring some order to the land, right? But things are bad in the far right. The idea captured here is perhaps common to most human societies, and that is, if things change too quickly, we might find ourselves in this disordered, chaotic dystopia, right? There is the desire to conserve or keep things as they are to prevent these sort of outcomes. And John Haidt's notion is that both liberal and conservative forces work together in a yin and yang sort of manner. So liberal forces encourage change, but the conservative forces prevent that change from happening too quickly, because there is some recognition that change can't happen too quickly. And I think at the time, there was the concern that society was changing very rapidly, far too quickly, and it was leading to the disintegration of society, and that LSD was responsible for that change. So Nixon used his influence to place psychedelics in this Schedule 1 of the Controlled Substances Act. That's the most highly restricted category. And use his influence further to essentially force all UN member nations to do the same thing. So any UN member nation also placed psychedelics in Schedule 1. I think the hope was, let's forget that ever happened. Let's file that away. I think of one of my favorite childhood movies, which was Indiana Jones and the Raiders of the Lost Ark. Has anyone seen that? Can you raise your hands? I want to make sure if my references to some of you will make sense. You've never seen that, Otto? I can't believe that. Okay. Well, I'm dating myself, right? I was born in 1976. So in the movie, Indiana Jones discovers the Lost Ark, and it appears to have very strong powers. The Nazis wanted it in this movie. but the Americans were able to obtain it. But because they're concerned about its power, they lock it in this wooden box and file it away in this huge warehouse in the end. Like the idea is like, we'll just put that away and hopefully forget all about it. And I think that's what Nixon was hoping to do with psychedelics. Like, whoa, that was crazy. Let's just put those away and pretend it never happened. And for some of the responsible scientists like Humphrey Osmond, this was really disappointing because they were doing some good work. They were really enthusiastic about what might happen in responsible and controlled medical contexts, but they were told, no research ever again, move on. And a guy like Humphrey said, okay, and he became a schizophrenia researcher for the rest of his career. Many people were disappointed, but that was the nature of things at the time. So the question is always, were these changes justified? Was there a scientific or medical rationale, or was it only politically motivated? So this might be too small for you to read. Perhaps not. I'll walk you through this. So there were two studies published, first in the American Journal on Drug and Alcohol Abuse, and then in Addiction, on the dependence potential and acute toxicity of the range of psychoactive substances. So on the horizontal axis, you have how addictive a drug is, right? So if you're on the far left, it is a drug with very low dependence potential. If you're on the far right, it's a drug with very high dependence potential. And then on the vertical axis, you have how likely the drug might be to cause a fatality. So at the top of that axis, you have a severe risk of fatality. At the bottom, it's a very low or negligible risk of fatality. So the drugs in the right quadrant would be the very dangerous ones. They're addictive and they're fairly easy to overdose on. And in the bottom left, you have those that are neither addictive nor could you overdose on them very easily. Now, a highlight in the top right, we see heroin, intravenous heroin, as being very addictive and having a very high risk of fatality. And there are other drugs there. Alcohol's in that quadrant. I could probably find a beer within 5 minutes right now if I wanted to, right? Okay, so one of the more dangerous drugs widely available. Cocaine is there, amphetamine is there, nicotine is there too. There's only a little bit of nicotine in tobacco, fortunately. In the bottom left quadrant, though, you'll see psilocybin and PO in the US, that just means taken by mouth. So oral psilocybin is in the very bottom left, and LSD is there too. So some people have asked me before, well, how could one overdose on psilocybin? It would be difficult. I don't know that it's really possible. It's sort of theoretical, but usually, if somebody wants to have a very powerful experience, naturalistically, they might ingest 5 grams of dried mushrooms. 5 grams. To overdose on dried mushrooms, I've read that one would have to consume maybe 25 pounds of dried mushrooms, 25 pounds. And to put that in perspective, steakhouses are very popular in the United States. So you'd go to like a restaurant, order a large steak. And at some of these restaurants, there will be a challenge where if you can eat this very, very large steak, you get your picture up on the wall. And they're normally huge. And the people with their pictures on the wall are, 6'7", and they weigh 300 pounds. They're just very, very large men who can eat this much steak. And usually these steaks are 3 pounds. So if you could eat 3 pounds of steak, you would be, enshrined on a wall. So I don't think anybody here could eat 25 pounds of mushrooms. That would be amazing. So it would just be impossible to overdose. So these findings here would suggest there may not have been a scientific rationale for these changes. Here's another study. This was published in The Lancet by David Nutt. I think some of you might know him. He's in the UK. And David Nutt essentially convened a panel of experts to review the literature on the drugs of potential misuse that are present in the UK. Some of these, like khat, you would not find in the US. Khat is a plant native to East Africa, and it contains cathinone, so it's like a stimulant of sorts. But in any event, he had them review the literature on all the drugs that people might abuse or misuse in the UK, discuss with each other these findings, and then rank the harms posed by these substances on this scale, as you see, that goes from 0 to 80, and they broke down the harm posed by these drugs by both harm posed to others in red and harm posed to users in blue. And you can see that the number one most dangerous our most harmful drug was alcohol with a score of 72, followed by heroin, and then crack, and then methamphetamine. At the very bottom of the list, we find mushrooms, buprenorphine, LSD, and ecstasy, with most or all of the harm posed to the user in the case of mushrooms. They couldn't identify any harm to others. So I think the answer from the available data would be that those changes were not justified, that these were politically motivated. So we find ourselves in the midst, I use the term Renaissance lightly. If it were a true Renaissance, I think we'd see this work across the globe, and there would be just dozens of research reports every month. And we're not there yet. I would love for that to happen. So it's a very modest Renaissance. It's a very modest rebirth, but here we are. And it really started with Rick Strassman's work in the 90s on dimethyltryptamine. I think he was able to do that work because most people were unfamiliar with it. It wasn't one of those psychedelics that most people were familiar with. And he was administering IV dimethyltryptamine and what you might consider behavioral pharmacology studies, but very interesting studies nonetheless. Here are two of them. This was followed by perhaps, though, the most important study. This was a study that was published by Roland Griffiths and colleagues on the effects of psilocybin in healthy volunteers. And in this study, healthy volunteers rated these experiences as among the most meaningful of their lives, with long-lasting positive benefits, enduring changes to mood and mental health, well-being, and the way in which they interacted with those in their lives, being sort of kinder, gentler people after having just one experience with psilocybin. People always ask me, how is it that I came to be interested in this line of work? Otto mentioned I'm a clinical psychologist by training. A lot of my work in graduate school was on smoking cessation and cognitive behavioral methods for smoking cessation. How in the world did I end up doing this work? I mean, if you had told me in graduate school I'd be here today talking about this, I would have said that couldn't possibly be true. That sounds absolutely absurd, that I'd be doing research with psilocybin. How would that happen? Well, this article was published, if you look in the top left corner, in Psychopharmacology 2006, issue 187. Well, it just so happens that my dissertation was published in the same issue of the same journal. And why is that relevant? Well, they sent me a complimentary copy to my little postdoc office, and I took the plastic wrap off this journal and I opened it up thinking I'll see my name in print for one of the first times ever. And instead I opened the journal to this article, and I was transfixed because I was raised, my formative years were in the 80s. I was born in 1976. So my formative years were in the 80s, just outside of Washington, D.C., during the Reagan administration, which would have been at least one of the peaks of the war on drugs. And I would have assumed at the time, any drug that's illegal, it's Schedule 1. I probably wouldn't have known about schedules, but any drug that's illegal must be dangerous and addictive, because that's what the government has told me. My father was a lawyer with the Department of Justice. Oh, I had reason to believe that these people could be taken at their word. To see this was, quite a disruption in my worldview. Wow. Okay. I just thought it was a hallucinogen, like you ingest it and you hallucinate. And that's all there is to say. Instead, people are having these transcendent, life-changing experiences. This is incredible. I took this study to my postdoctoral mentor at the time, and I said, we need to do this work. And she laughed and laughed and laughed and said, you'll have to do that when you're on your own. Good luck. I said, okay. And I waited and waited until, started to do some of the work I'm doing now. I'm very happy to be doing it. But this was my introduction. It really had nothing to do with personal experience, but this understanding that experiences that are subjectively spiritual or transcendent can really change behavior made sense to me, as it probably does to everybody. Because I think if I asked any one of you, like, why do you do what you do? Why are you here? What's your purpose? You'd probably be able to name something transcendent, meaning like something bigger than who you are. Like, I'm here to make a change to humanity, or to live in service to my loved ones, or whatever it might be. But we all are ultimately motivated by that sense of something bigger than who we are. I had a slide devoted to Otto. It didn't make it in this version, but I do want to point out Otto is doing some really fantastic work. He's a publication machine, but I mean that in a good way. He's producing some really high quality science and some really interesting work indicating that that psychedelics might have implications for health behavior change and leadership style. And I would encourage you to talk to him because he's doing some really fascinating work here. I hope I didn't embarrass you too much. Your picture's not on the slide, which was my original plan, but there he is. Okay. So I'm going to present just very briefly some of the research that's been conducted to date. You might think it's not directly relevant to substance use disorders, but I would say it is. And why? A leading theory of drug use motivation, meaning a leading explanation for why people use drugs time and again, is that they do so to escape or avoid negative affect. And what does that mean? That means when someone is feeling anxious or sad or irritable or angry, they will reach for that substance as a way to cope with that mood, as a way to prevent that mood or escape it altogether. And for someone who's really addicted, and by the way, that word is derived from an old Roman term that means to be slave to something, right? So for someone who's really slave to their substance, that becomes their primary coping mechanism. So you think of a smoker, anytime I feel stressed, I smoke. Better. Every time I feel irritable, I'm angry at Otto, I smoke. Every time I feel sad, I smoke. And it works every time, although I have to keep returning to that behavior just to feel okay. So this leading theory suggests that that is the primary reason that people who are dealing with substance use disorders continue to use substances. So the literature on psilocybin in this case and depression and anxiety, I think is very relevant, because if the literature would indicate psilocybin could be effective in the treatment of some affective disturbance, it would have relevance to substance use disorder. So this was a study conducted by the Hopkins team, Roland Griffiths, and there was a parallel study at New York University, and they were evaluating what they called anxiety and depression in people with advanced stage cancer diagnoses. I think a better way of thinking of it is end-of-life distress. People who felt demoralized because there was a very high likelihood that they would die soon. And they found in this study a very robust and rapid effect of psilocybin in reducing these feelings of depression and anxiety. I mean, the effect sizes were just massive. You don't even need statistics to see. You can see with your own eyes what happened when people were administered psilocybin. Michael Bogenschutz, now he recently released his larger results in JAMA Psychiatry, and I haven't yet had the chance to really read through it carefully to include it in a slideshow. But if you get the chance, in JAMA Psychiatry, I think just a couple of weeks ago, he released his randomized controlled trial findings with a placebo control. But in some of his earlier work, he also found some very promising results with regard to the treatment of alcohol use disorder. And in this study, see, after the first psilocybin administration, there was a reduction in alcohol consumption that was sustained through 9 months. So these were folks who were heavily drinking. In red, we have percentage of heavy drinking days. So these were folks who were getting quite intoxicated 10 to 15 days out of the month. And after just one administration of psilocybin combined with motivational enhancement therapy, you see a reduction that was generally maintained such that 9 months after, or 9 months later, at the very end of the study, they were still drinking, but in this case, maybe only 3 to 4 to 5 days out of the month. So a very dramatic reduction in heavy drinking that was very likely met with a number of changes in quality of life. This, of course, comports well with that older literature I indicated in that meta-analysis. Matt Johnson at Johns Hopkins is doing some really fun and interesting and fascinating and promising work with smoking cessation. And this study, which was a single-arm open-label trial, so we have to interpret these results cautiously, he found that 12 of the 15 participants quit smoking after having the option to have up to 3 sessions with psilocybin. A number of the participants did not care to have a third session because these experiences are often very intense and difficult, and the addictive nature of psilocybin is quite low. People generally don't enjoy these experiences too much, so it makes sense that some people passed on their third. But after these experiences, you see that 12 of these 15 participants were abstinent at 6-month follow-up. He hasn't yet released his randomized controlled trial results, but as I understand, they're quite promising. We've also seen some really interesting work with depression, with treatment-resistant depression and major depression. This was one of Robin Carhart-Harris's earlier open-label feasibility studies, and we have seen similar such results where there's a rather rapid and sustained reduction in depression with ayahuasca. Now, Robin has since published findings in the New England Journal of Medicine comparing psilocybin to escitalopram. The trade name there is Lexapro, and the results generally showed that the outcomes with regard to depression are about the same, although there were some secondary analyses that generally indicate psilocybin might outperform escitalopram with regard to depression. The group at Hopkins has also done some work. This was in JAMA Psychiatry on the effects of psilocybin in major depressive disorder, not treatment-resistant depression. And here too, they see a sort of rapid and sustained effect on depression. Now, it doesn't work for everybody, but for a good number of people. And I think one big question moving forward is how we predict treatment response, because we know not everybody will respond, but it would be really interesting to know how we predict who will respond and who won't. My friend Brian Anderson did, I think, one of the coolest studies in the modern era. Here he recruited a sample of gay identified men in San Francisco, California, older men who had survived that first wave of the HIV epidemic. Okay, so these were men who, for whatever reason, contracted HIV, but survived, but saw many of their very best friends die. And they felt demoralized, which is a very specific concept that gets at feeling like life has no purpose or meaning. It's a bit different than depression. It overlaps with depression, but it's different and especially difficult to treat. And in this study, after one administration of psilocybin, you can see there's no control group. It's open label, single arm, but still there was a nice dip in demoralization, with a slight rebound, but a reduction that was nevertheless maintained through the 3-month follow-up. Now, I want to talk a little bit about this pilot trial that we're conducting now. I'll show you some of the preliminary results. We are testing psilocybin in the treatment of cocaine use disorder or cocaine dependence. And one question is why? Why am I interested in cocaine use disorder? I've generally worked with smoking cessation. Why cocaine? I would tell you that my interest really always did lie in these illicit substances that lead to more acute dysfunction. Smoking certainly is a major public health issue, but tends not to produce acute dysfunction, meaning people who smoke can function quite well. The problem, of course, is that in 20 or 30 years, they develop heart disease or cancer. But it's a very helpful model to understand addiction in general. And as my graduate mentor told me, if you want to finish graduate school in a timely fashion, it's a population you should focus on. And then when you leave, you can focus on more difficult or recalcitrant populations like cocaine users. Here's an example. This was a study my postdoctoral fellow Sarah Lappin and I did a meta-analysis of dropout rates in clinical trials that target substance use disorder. And here we found in the third column that the rates of dropout associated with cocaine, so trials that targeted cocaine use disorder, were nearly 50%. And for major stimulants, the rate of dropout is quite high. You can see for methamphetamine, it was 53%. And then for major stimulants in general, again, approaching 50%. That's quite a bit higher than all the other classes, right? For alcohol, it's more like 25. For tobacco, it's 25. Might be a bit higher for opioids. But the point here is that major stimulant users are a very challenging population. It's very hard to get them to engage in treatment. The rate of dropout is quite high, and there are no approved pharmacotherapies. Nothing works for major stimulant use disorder or cocaine use disorder, but it's very strongly associated with criminal behavior. It's very strongly associated with a range of impulsive behavior, including risky sexual behavior. In the US, the sort of resurgence of HIV has been attributed in part to methamphetamine use. And the director of NIDA, Nora Volkow, is very interested in finding a pharmacotherapy for major stimulant use disorder. So if our hypotheses are supported as we continue this line of work, And if psilocybin is indeed safe and effective in the treatment of cocaine use disorder, it would be the first ever pharmacotherapy found to treat this condition. So we are very excited to be doing this work and hopeful. So we are almost finished with the pilot trial of 40 individuals who meet criteria for cocaine use disorder. And today I'm going to show you results from the first 10 participants. You might wonder how I have these data. I have a data safety and monitoring board that I don't know if these are common here. Yes, okay, good. I have a data safety and monitoring board that asked me to unblind my first 10 participants, in part because they had heard the news about psychedelics and they were wondering if I should include a crossover condition in my study. I don't. It's a simple between groups design, placebo controlled. Those who receive the placebo do not have the option of receiving psilocybin at a later point. I've kept it that way because I think that's the most simple design, but also this population is very difficult to retain in trials, and I did not want to add another layer of difficulty in doing so. But in any event, I'm going to show you results from the first 10 participants. So here's the protocol. It's involved, it's intensive. It's much more intensive than most interventions, but I'll walk you through it. Okay, so the first thing our participants have to do is show that they can come to appointments before we begin to really invest some time in them. So they come to 2 pre-screen appointments. They have to come to our office, they complete some basic questionnaires, and we assess them at that point for hypertension. If they are hypertensive, if they have high blood pressure, we ask them to see their primary care provider to receive medication, because one of the exclusion criteria would be hypertension. The reason for that is psilocybin can increase blood pressure by 10 to 15 points, which is really quite modest, but if you have hypertension, it could be dangerous. This is a challenge in the US because if you do not have insurance, you will not have access to these medications. And many people don't have insurance. Many people cannot pay out of pocket. So some of our participants have had to be dropped because they have hypertension and they have really no way of addressing it. And there's nothing we can do other than to encourage them to seek out that treatment somewhere. We also include a medical exam, and we ensure that our participants are generally healthy, which just means that we look at a blood panel. The blood panel is normal, and we look at an EKG. The EKG appears to be normal as well. But keep in mind, these are people who are using a major stimulant pretty regularly, so we are pretty confident that if they can do that, they can probably use psilocybin one time. So after we've gone through that process, we begin what we call preparation. Preparation is combined with an empirically supported and manualized cognitive behavioral therapy for cocaine use disorder, developed by a group at Brown University in the 90s. But in addition to this manualized CBT, we spend some time establishing rapport, therapeutic alliance, expressing empathy with our participants. So these are the client-centered sort of component of the intervention, with the idea being that when we administer the drug, participants might very well have panic reactions, they might feel very anxious, and it's important for them to feel very comfortable with us, to feel very comfortable with the idea of the study, to know that they can rely on us for emotional support. All of this is important because one of the better predictors of response to psilocybin acutely would be one's willingness to surrender to the experience, being in a psychological state of surrender. So people who are in this psychological state of surrender have a much more beneficial experience. They tend not to have a challenging experience. They tend not to respond with anxiety. But those who are unwilling to surrender tend to have a much more challenging experience. And though this hasn't been tested, the assumption is if they have strong therapeutic alliance, if they feel comfortable with us and the study, that they're more likely to surrender to the experience. We administer the drug one time. Now, I've included here that we do have an MRI. I'm not going to provide those results today, but we do scan our participants' brains right before and then right after. I mean, the day before and the day after, not acutely. I'm not putting anybody in a scanner that I don't think would be good for the therapeutic outcomes. But we administer the drug one time in what we call a clinical research unit, which is an outpatient research ward. There's a team of nurses on hand, and we have physicians on call if anything goes awry. We have never had to intervene for any reason. Nobody's had a hypertensive crisis. No one has needed a benzodiazepine or an antipsychotic to manage the subjective effects. It's generally been smooth sailing. We have, I should mention, a placebo comparator. In this case, it's diphenhydramine, which is an antihistamine you'd find in the medication Benadryl. Do we have that here, Benadryl? Or is that just a US? No. It's an allergy medication, over-the-counter allergy medication, and we administer 100 milligrams of diphenhydramine as our control. It's double-blind, I would argue, at least until a few hours after we administer the drug. The day after drug administration, we begin the integration process. We really just meet briefly with these participants to make sure that they're okay and that there are no immediate adverse events that we need to address. We haven't had to address any. We haven't had any adverse events to report, which is, very surprising, but a very pleasant surprise. And then we meet with our participants 4 more times. This is very intensive, with the idea being here that we're going to continue working on the CBT, but also try to translate any insights that may have taken place into concrete adaptive behavior change. And often it's very straightforward. So someone might have had the insight that one reason I use is Otto's my best friend and Otto smokes crack every day, and I think I need to stop spending time with Otto. Okay, let's find a way that we can break up with Otto in a way that won't hurt his feelings, but that we know is best for you. Or, hey, I just realized I really need to spend more time with my daughter or reconnect with my son. How do I go about reaching out to them, telling them that I've changed now, that I'd like to maintain this relationship with them? So we do some very basic work, and you might call it behavioral activation, though that's not technically what it is. We're really just trying to support them in making this behavior change and ensure that these changes are adaptive. So far, no one's had any bad ideas. Like no one said, I think I should start drinking more. That would be bad. After the final follow-up session, this is EOT, end of treatment, we have assessments that take place day 90 and day 180. So 3 and 6 months after the last session with us, we do assessments only. And those assessments are conducted by one of my staff that are blind to the treatment process. We're not involved, have no notion as to what this individual may have received. So we're trying our best to maintain the blind, at least in our assessment. But I think there's very likely an issue where the therapists who are in the room with the participant at a minimum are very well aware of what the participant has received. And we can talk about that, but that is a weakness of these trials, I think. So let me tell you a little bit about the sample to date. They've been mostly men. They have been mostly African-American. About half the sample has a high school degree or less. Some have been homeless. About half make less than $10,000 per year. That is well below the poverty line. That would be extremely difficult to live on. About half are unemployed, and the mean age is mid-40s. So this is a very low income sample, in some case homeless, of primarily African Americans in the Deep South. Their lives are challenging and chaotic. Difficult, very, very difficult. And cocaine certainly isn't helping. Okay, let's first talk about challenging experiences. Okay, so these are questionnaires that are completed immediately after the session. So at hour 7, after the acute or subjective effects have passed, we ask people to try to explain their experience in part by completing some quantitative self-report measures. The challenging experience questionnaire tries to capture some of the less pleasant aspects of the experience. And there are adjectives that anchor each number, okay? So 0 would represent none, nothing. 1 would be, so slight, I cannot tell. 2 would be mild. 3 is moderate. 4 is strong or very strong. And 5 would be extreme. So those who received psilocybin are in red, placebo is in white. None of these differences are statistically significant, but look, the sample size is 10, so statistical significance is not especially relevant here, but still. You can see that there might be more challenge associated with psilocybin than the placebo, as you might expect, but note that even with fear, which has the highest mean score, The adjectives that capture this experience lie somewhere between so slight I cannot tell and mild. So that's good. The interesting thing about self-report is it probably doesn't capture some of the dynamics here. I think there are moments, brief moments, where participants might feel very afraid, but they tend to be fleeting, and the remainder of the experience is characterized by joy and amazement and wonder and feelings of unitary consciousness, things that I think you're probably all familiar with if you all know a little bit about psychedelics. So I liken the experience often to the first time I took my daughter, who's now 11, on a roller coaster. And when she got in the roller coaster, she was very excited. She was ready to go. She was excited to be riding a roller coaster for the first time. And we turned a corner and started to climb the first hill. And she looked around and she said, "Wait a second. All right, never mind. Take me back. I don't want to do this." And I said, "We're strapped in, and the only way we can finish this ride is to ride all the way through. We can get off when the ride is over." "No, Daddy, tell them to stop. I want to go back. I don't want to do it. I don't want to do it. I don't want to do it." Too late. Enjoy yourself. And of course, she had a great time and was squealing with joy. And at the end, she said, "That was great." And if I'd asked her then, "Were you scared at any point?" she would have said, "No, it was fine." I think people sometimes have that experience. So during the first hour or so, they might look around and say, "What's going on? What'd you do to me? I don't want to be here anymore. I want to go home." Very common response. And we tell them, everything's happening just as it should. You're in a perfectly safe place. You're in the safest place to be. You won't be going home. Just do your best to, dive into the experience, immerse yourself in the experience. And the idea is, if they have a good relationship with us, they'll look at us and realize, "Oh yeah, I know this guy. I can trust him. I can move forward." This is no small feat, because I am not only the principal investigator, but the primary therapist on the trial, which is also not ideal in terms of controlling for bias. But this is a small pilot study. We have very few funds, so we've had to donate our time to the study. But here I am, a white therapist working with primarily Black men. And I don't know if any of you have heard about the Tuskegee studies that were conducted in the US. Can I see some hands? 1, 2, 3, 4, 5, 6, a few, but not everybody. So the Tuskegee studies are now often taught as one of the most unethical things you could do in science. Were some studies conducted 45 minutes from Birmingham in Tuskegee, Alabama. And there, a sample of Black men with syphilis were told, "We're going to treat your syphilis. That's the purpose of our presence here." But rather than being given any treatment at all, the time course of syphilis was observed. Right. So these are people who are told you're being treated. Instead, they were just observed because the US government was interested in what syphilis might do. We have had some participants say beforehand, sometimes jokingly, but there's some seriousness to what they say, "Is this another Tuskegee study? This sounds crazy." For some reason in the US, psychedelics are strongly associated with more educated people and with white people in particular. So many of our Black participants, when they look at the informed consent form, would say to me, "This sounds crazy. Yes, I've heard of psychedelics, but psychedelics are drugs for crazy white people. And I can't believe you think you're going to help me stop getting high by getting me high." And I try to empathize with them and try to be very transparent and explain what our rationale might be. But we had one participant who, after his experience, very jokingly told me he had a great experience. But he told me at one point, when he was feeling very scared and paranoid, he looked over at me and the co-guide, who also has lighter complexion, blonde hair and blue eyes like I do, and thought, "What did these white guys do to me?" And he thought for a second, "I am getting out of here. This must be another Tuskegee experiment." So, I'm hopefully not saying this to brag about the job we've done, but what I am saying is I do think it's very, very important to put in that work to establish rapport and alliance, because people have very intense experiences that can be characterized by panic and fear. And if they don't feel really comfortable, I think that's where things could go awry. And if we didn't put in that time, I wouldn't be surprised if some people got up and ran out of that room. And that generally these challenging experience scores for now have been low, I think suggests that we're generally doing a good job. Now, the next question is, what about the mystical experience? Because the mystical experience appears to be what is responsible for the therapeutic effects of psychedelics. We want mystical experience scores to be high. We have a mystical experience questionnaire. It uses the same scale, where 0 is none, 1 is so slight I can't tell, 2 is mild, 3 is moderate, 4 is strong, 5 is extreme. I'm going to show you those scores right now. Okay. I know I shouldn't have done any statistical tests, but I did. These are all statistically significant. They're all different. Okay, and you'll see that the scores on average are somewhere around strong or very strong. So they don't quite reach extreme, but strong. This transcendent scale, it's very esoteric, and for participants who may have dropped out of school, say in the 7th grade, that would be like around age 12 or 13. When you ask them questions like time and space had no meaning, they look at me like, what are you talking about? These are odd questions. I think self-report measures that were developed by people with doctorates and then administered to people who may not have finished even middle school often don't work too well. And trying to capture an experience that's supposed to be ineffable, meaning you can't describe it in words, with a self-report questionnaire is folly. It's kind of silly that we do that, but we try. Still, people generally tell us they have pretty intense experiences. And this isn't a population that I think is sometimes very hesitant to admit to this, because this part of the US tends to be very highly religious, something we talked about last night. So Sweden is not a very highly religious place. That's fine. The deep south of the US is, and these participants are very explicitly Christian. And there is a long history of Christianity among African Americans. And many historians would say that religion became a very substantial part of their experience with slavery and understanding their own suffering, and many would feel very strongly connected to that tradition. So to ask somebody if they had a proper spiritual or religious-like experience in a hospital with a drug, they're often not quick to suggest that that was the case, because they tell me, I think I should have had that sort of experience in church. I'm not sure I should have had that sort of experience here with you. So I think that we have these results suggest that something is happening, especially because my sense is that many participants would rather not really even admit to this sort of experience in a hospital. This is really interesting to me. So the N is 10, 6 received psilocybin, 4 received placebo. We ask people to tell us how spiritually significant was this experience. Among those who received psilocybin, half of this sample, 3 of the 6 said it was the single most spiritually significant experience of my life, which is unbelievable to me. I mean, despite having hypothesized what I did, I couldn't believe that when I saw that. And I was just sitting in the room watching it happen. 1 said it was in the top 5. Nobody who received placebo endorsed either of those categories. Okay, follow me here if you can. This is our main outcome. Percentage of abstinent days. Okay, in the major stimulant literature, scientists have long let go of the idea that people might quit and stop using once and for all, okay, because slips are very common. This is the case with alcohol too. You saw Michael Bogenschutz in his study. He's not looking at complete abstinence, because it's very rare for someone to stop drinking and never use again. You want to see the frequency of cocaine use, alcohol use decrease. Or in this case, we want to see the number of abstinent days increase or climb. Okay, so at baseline, you'll see, again, psilocybin's in red, placebo's in black. There's a lot of variation in the report that we get. But we ask people in the past 90 days, how frequently have you been using cocaine? And they're generally reporting every other day, about half the time. Sometimes they use a lot, sometimes they use a little. It's very hard to quantify how much they use. We can ask them how much money they spend, but that doesn't really work, because people might use other forms of currency. Sometimes they trade sex for drugs, and they're often networks that these users have where they might not spend anything on cocaine if a friend provides it today, and they'll provide the cocaine another time to their friend a week later. But generally, people are only limited by their finances. Using every other day, maybe they'd use every day if they could. Now, this next time point, pre-2 to P1, what does that mean? This is from the period of time that we're beginning to have contact with them. They're going through the pre-screening process, but they haven't received any behavioral intervention yet. What happens? You'll see there's an increase in abstinence. And this is a rather consistent finding in the substance use literature. Per, I think we were talking about this, right? When somebody is ready to change, they've decided to be in the clinical trial, they start changing before you ask them to. That's what they do. So people begin to change. They begin to increase in abstinence before they start working with us. This next time point is during that preparation period, before we've given them any medication, but we're providing an empirically supported cognitive behavioral treatment, we see again an increase in abstinence in both conditions. This is nice, right? This indicates that behavioral treatment does work and that we're generally doing a pretty good job. People report an increase in abstinence. What's most interesting, though, is the period of time after we've administered the drug, that's DA, drug administration, to end of treatment. And here we see, just to allow you to interpret this, that among those who received psilocybin, every single participant reported 100% abstinence during that time. That's why there's no error bar around that point. They all said, didn't use a thing. There's a slight decrease among those who got the placebo there. At the day 90 follow-up, you'll see that there's been a slight dip. So some of the people who received psilocybin reported some slips, and I'll tell you a little bit about that in a second. But at the 180-day follow-up, those 6 people said that they were completely abstinent. Again, no error bar around that time estimate. Now, the people who got the placebo are also doing quite well. And the reason for that is they got a very intensive intervention, and they're very motivated people who had to jump through a lot of hoops. These are people who, when they saw us, told us, I want to stop using once and for all. I'll do anything it takes. I'm sick of this. I have to make a change. So they're really, really, really motivated. And even those who got placebo received an intervention that we know works, and they made it all the way through. So we should expect them to be doing pretty well. Again, I conducted some very simple statistical tests, and I did find that there were differences between these conditions at that period of time from after the drug has been administered to the end of treatment and at that last follow-up. The Cohen's d effect sizes here, they're silly how large they are. I mean, these findings couldn't possibly hold up when I actually finished data collection. So, take this with a big grain of salt, but just to give you an idea of what these very preliminary initial findings suggest, there's probably something going on here. Okay. Now, I wanted some qualitative information you might find interesting. Not all, but some participants will go this long time without using, but then they'll have a slip. Right? Something will happen. They'll have a slip they might use a few times, and then they get back on track. And I've asked them, to describe that process, and many have said, Doc, it's like you've broken up with your significant other, with your girlfriend. Right? You knew it was a bad relationship. And then you hadn't seen her for months, and then you're out and you see her and you realize, oh, she looks great and things weren't that bad. And I think we could probably try again. And you get back together and then you realize right away, oh man, there's a reason we broke up in the first place. Then they go their separate way. I don't know if anybody's had that experience before in the room. I think that might be, yes, thank you for admitting to it. I bet everybody, yes, thank you too. But that's a really interesting way of talking about it. And there actually is one theory of addiction that likens that drug use to what they call an affiliative attachment, a relationship where people will say, I have a relationship with the drug. And in this case, sometimes people would say it's like a really bad abusive relationship. And man, why did I do that? I can't believe I did that. But slips are really, really common. And I think what's important here is not that you never slip, but do you get back on track after you do so? And to date, this very limited data suggests that they do. Okay, I've come up with a little video. My graduate student helped me with this. It's meant to be kind of silly, but the question here is, what exactly is taking place with psilocybin? What might be happening? I was just in Colorado at the Telluride Mushroom Festival, and there was a mycologist who gave this really interesting presentation, and the data to date suggests that psilocybin is produced by the mushroom as a pesticide. It prevents slugs and snails from eating the mushroom, right? So like a pear, I've heard that pears are very good in Sweden. Yes, I think your wife said that last night, Walter. Swedish pears are the best. So the tree produces the pear so that you will eat it along with the seed and then take the seed elsewhere so a new tree can grow. That's its strategy, to provide you with a delicious thing to eat. The mushroom does not have that same evolutionary strategy. It does not want to be eaten. It wants to open up its veil and drop its spores. It doesn't want anything to come along and eat it. Snails and slugs apparently love to eat mushrooms, and psilocybin makes them dizzy, and it affects their appetite, and they wander away. It just so happens when humans ingest it, it does what it does to our our nervous system, which is fascinating. But I think what's more fascinating is the story here is not really about what the drug does, but the story is what our nervous systems do, what our nervous systems do. And because these experiences are so common, I think it says something about the nature of humanity. Anywhere on the globe, if you give someone psilocybin, they're going to have an experience in which they realize, oh, wow, we're all one, we're all in it together. They're going to have some insights, some novel insights they hadn't had before. And here's a video that I think captures this. So some of you might recognize this painting now. I'm impressed if you do, but you will in a moment. But here you see this young boy who sees before him a fly, a rather menacing fly. I'm going to pause this as I go. Okay, so, oh no, there is a mean fly. Okay, we introduce psilocybin, and what begins to happen? Maybe within 30 minutes. Okay, let's pause here. Something's happening. So you can still see this young boy here, okay? But attentional scope is getting bigger. Okay, so attentional scope was really limited. It's getting bigger. Things are getting bigger. There's access to more stimuli. And then, boom, everything opens up. Wow. Now, if you can still see this young boy, he's in the bottom right-hand corner. Do you see him right there? Does anybody know what painting this is? One of my favorite artists. No one. What's that? Yes, it's Salvador Dali. The name of this is the hallucinogenic Toreador. This is what I think it captures, right? So most mental health conditions are marked by a rather narrow attentional scope, right? It's as though you're experiencing life looking through a straw. And, that might be captured by kind of a pessimistic way of thinking if you're depressed, or a way of ruminating if you're anxious, right? You see the world through a very narrow lens. And that's also related to, perhaps in some ways a fight or fight response. I'm feeling, in the case of someone who's addicted, this urge to use. I want the drug. I want to get the drug. Where can I get the drug? How can I make these feelings go away? Where can I get the drug? And you're ignoring the other stimuli in your environment because you're so laser focused on this experience you're having, this urge you're having, the withdrawal symptoms you're having, your desire to use the drug. And many other mental health conditions are sort of marked by this process where people would say it feels like I just have this tunnel vision and can't escape this way of seeing the world. For whatever reason, when we ingest this natural pesticide that the mushroom produces, our attentional scope suddenly broadens. It's as though someone has taken that straw from your eyes and you're looking up at the night sky for the first time. Whoa, that's incredible. And it's so incredible, you forget yourself for a period of time. This is reduced self-focus. You're suddenly thinking outside of yourself. Whoa, that's incredible. And people often feel liberated from this sort of pathological self-focus. They feel liberated, and because they're seeing things in such a magnificent way, and their attentional scope is so broad, they make novel insights like, oh, you know what? I hadn't thought about this, but my pursuit of cocaine has ruined relationships that really meant a lot to me. And many people have said this. Oh, my children I haven't spoken to in years. I don't have a relationship with my mother or my father or my siblings. And that can be really, really difficult to realize that. That's when tears often come. Like, oh, I've ruined relationships. I can't believe I've done that. I can't believe I've done that. Oh man, I can't believe it. Like it's I think often for many people very sorrowful. And we've had some participants even only 3 or 4 hours into things saying, hey, I've got to go. I got a lot of work to do. And I've looked at them and said, did you schedule work today? You going to work? No, I've got to contact all my siblings and my children, and I've got to make amends. I've got to get out there, and I've got to start now. And I'll say, okay, just wait a few more hours, then we can do that. That is a really common experience. I think that's because people are freed from this narrow attentional scope. That's an idea that we have. Of course, we can test that empirically, but I think that's what's happening. It's just amazing that I think it's just amazing that like a gastropod antifeedant does that to the human brain. But even more amazing that this is a common experience that humans have and that we have had without psychedelics, by the way. These sort of things happen all the time in organic, non-drug settings. And it's just incredible that across the globe, you'd see these sort of experiences. So I think really the story here is not about psilocybin, but about what it means to be human and to make connections and to find meaning. So a couple things I wanted to say. Some of these slides might be especially relevant to the US, where we do not have socialized healthcare, or we have a for-profit healthcare system. But I now often think about the future, and I think this is relevant to young scholars, people interested in psychedelics. Sometimes we see this this curve. I can't remember the formal name for it, but this is a hype cycle, right? And what we usually see, the innovation trigger, in this case, psychedelics are studied 2006 with the Griffith study, and we get these peaks of inflated expectations. I don't really think that we're quite there. I think in the world of science, scientists are doing what they do well. We're being objective, we're trying to be dispassionate, we're trying to be skeptical and critical of this. But I think in the world of investing and in the world of media coverage, that there are these inflated expectations about what psychedelics can do. And typically there is some trough of disillusionment. I don't think we've reached that point yet, but I think it's possible that it could happen. And it could happen, say, when psychedelics are approved for use in clinical settings and patient populations don't quite experience the same benefit that the clinical trials would have indicated. And why would that happen? Because the people who are doing the clinical trials are really committed to what they're doing and maybe are very, very good at what they do, but in the real world, people aren't quite as committed or aren't quite as good at what they do. And Per, I'm sure you could point the students you've had to findings that indicate effect sizes in clinical trials often reduce pretty substantially in the real world. So I think that's one concern we might have. When this goes to the real world, it won't be quite as effective as it was made to be, at least by the media, and people feel disillusioned. And I think we have to be prepared to deal with that trough of disillusionment so that we can reach a point of enlightenment. So some ideas I have about that going forward. We discussed this at lunch, Otto, so you'll have to hear it again. Here's another area where we might find some disillusionment. So Art Linkletter was a famous TV personality, actually Canadian, but well known in North America in the 50s and 60s. And he hosted the show called Kids Say the Darndest Things, where he'd interview very young children, like Walter's children, and they would say really silly things, because kids always do. Like, tell me what you think about the state of Swedish politics. And what would your child say if you asked them that? Probably something hilarious. So that was what Art Linkletter was known for doing. Very tragically, his daughter committed suicide, and he felt that LSD played a role, because before she committed suicide, according to his report, she told him that she had used LSD and that it had upset or disturbed her in some way. And she jumped out of her Hollywood apartment. And understandably, as her father, he was just devastated by this. And he made it his mission to spread the word of the dangers of not just LSD, but drugs in general. And I think because of this one very tragic case study, to this day, many people have this idea that if you use a psychedelic, you'll jump off a building. How many people have heard that sort of thing before? Yeah, I think it's mostly because Art Linkletter was able to sort of spread this word. I mean, there was also a man named Frank Olson, who is said to have committed suicide. This was an American who is said to have committed suicide in New York. There's a very good documentary called Wormwood that suggests the CIA had in fact killed him, threw him out of this window and made it seem like a suicide. But there was that made headlines. But there's this general thought that psychedelics and suicide are linked, even though the data actually show that psychedelics reduce suicidality. But if something like that happens in the real world, the media will latch onto that, and they'll even point out that, hey, psychedelics were supposed to be game changers, and instead people are getting harmed. And never mind, the media were the ones who were hyping up psychedelics in the first place. But this is what often happens. The media builds you up, they start talking about how great psychedelics are, then one bad thing happens, and they will tear you down. So my feeling is when and if, I think it's more likely when, an adverse outcome occurs, it's just going to be hammered to death. The media is going to just stick to it, right? So if millions of people access psychedelics, it just takes one person who has a heart attack for the media to say, oh, look at that, it's dangerous. They said it was safe. We have to be prepared for that. So I think there are a few things that we could do. I think we have to provide a really realistic picture of the benefits, like be completely transparent from the beginning. So here's just an example, since I do some work in smoking cessation, and we're doing a smoking cessation trial now. The very, very best smoking cessation treatments can produce success rates of about 20 to 30%. That's not very good. So at the moment, gold standard treatment for 100 smokers means 20 to 30 actually quit. If we can double that, that would be a huge boon for public health, a doubling of quit rates, but that still means that for 40 to 60% of smokers, it's not an effective treatment. So if I have a clinic, I have 100 smokers, before 20 to 30 were quitting, now maybe 40 to 60 are. That's a huge, huge improvement, but it also means 40 to 60 of those smokers have still not quit after having received this treatment that they were told would change their lives. Michael Pollan's book, How to Change Your Life, or change your mind, I should say. So I think we should be very clear, no treatment works for everybody. In general, our mental health treatments are not very good. And that's why people like myself are doing what we do. If we have a really exciting treatment, from our perspective, it means we could double the quit rates, but it also means a lot of people won't respond. So a big focus going forward is figuring out who responds and who doesn't and why. Does anybody know this movie reference? Oh, Gustav, you know all the references. Anybody other than Gustav? Okay, good. This is from Full Metal Jacket, which is the director's name, one of my favorite. Yet I'm blanking. You could tell me, Gustav. Yeah, Stanley Kubrick. This is a drill sergeant. Okay, so in the US, and I think other countries, regulatory agencies will adopt something similar. We have what's called a risk evaluation and mitigation strategy, which means when psilocybin, when and if it's approved by the FDA will say, here's how you administer it. Here are the rules. Here's how you screen people. Here's how you monitor them. And you have to be faithful to this strategy, to this REMS. You have to do it. The thing is, in the US at least, I'm sure it's the case here, practitioners will often just do whatever they want. And we can't have that. I think we have to be very careful in training people to these REMS and maintaining that fidelity. We have to make sure people are really doing this carefully. They're going by the books, they're going by the manual. Because once people start to stray, that's when people are harmed. And because psychedelics are often associated with spiritual type experiences, sometimes, not always, the field can attract some interesting characters. And you've probably heard at least about some of the exposés that have been conducted about things that are happening on the underground. And one very troubling development there, I don't know much about the underground though, is that there's a kind of higher maybe than normal rate of sexual abuse that takes place. And, I'll say that clinical psychology, again, at least in the US, has a long and storied history of older male therapists exploiting younger female clients. Is that the case in Sweden too? I'm looking at you, Per, because you're the only clinical psychologist I think I've identified here. But I could also ask Gustav, right? Is that a problem? I think it's been a long problem in the US where older male therapists will initiate relationships with their female clients. I mentioned this because in some of the MDMA trials that MAPS was conducting, some of you may have heard, there was a therapist in one of their trials who initiated a relationship with a woman, a participant, who had a diagnosis of PTSD, a history of sexual trauma. And after her participation, she moved in with this therapist with his wife's knowledge and consent. And this is an egregious ethical violation. And I would say that this is the only that I know of with the MAPS trial, but there are some people who think that psychedelics, because of their really unique effects, might make people especially vulnerable to these sort of ethical violations. So I think we have to be really, really careful about how this treatment is provided, because if it shortly comes out afterwards that there's just a higher rate of this sort of abuse or exploitation, again, this is really going to hit psychedelics hard. And the concern is not just what this will do for the psychedelics image, but what it could do to the people who are harmed in the process. So I think we have to be really careful about that training. Might have one more slide? Yes. The last thing I'll say, okay, this might be especially relevant to the US. If you have socialized medicine, congratulations, you figured out how to do things. I don't think that'll ever happen in the US. It's too weird for that sort of thing to happen. But for countries that don't have socialized medicine, we have to have conversations with insurance companies now. How are we going to make this work? How can we partner with you? The issue will be that these paradigms so far are intensive and expensive. They're very time intensive. So these insurance companies are realizing I'm going to have to pay for a lot. And what are we getting out of it? And if the argument is in 10 years, this person won't need open heart surgery or say chemotherapy, in the case of smoking, the response would be in 10 years, this person will no longer be a customer because they cycle out of these programs every 1 or 2 years. So how can we come up with a model that they'll be interested in participating in? The bottom line is there has to be a business model that makes sense. And it kind of pains me to say that. It does pain me to say that, but there has to be a way that we can do this and generate some appropriate amount of revenue. I think that is my last slide. So hopefully we have time for questions now.
Yes, we can do about 1 or 2 or 3 brief questions. So no statements, questions, please. So you can raise your hand if you want to ask a question.
When you presented the slide with the dropouts, with the cocaine and all the different types of, I kind of thought of people dropping out for other reasons, like having ADHD or PTSD or whatever other. So then I thought about how have you looked for that type of psychological background when you do your study?
Oh, so if people are dropping out of this trial, understanding why?
No, like, is that some requisite that you check for before you do your study?
Oh, yeah. So good question. So our participants would be ruled out if they meet criteria for any other DSM-4 diagnoses. We started this really before DSM-5 was used regularly, but generally we would not want them to have any other mental health conditions. That's a rather common practice in clinical trials. It does mean that you have a kind of an odd sample of relatively homogeneous people, but these would not be people who meet criteria for, say, PTSD or ADHD as best I can tell, or really any other mental health conditions. I hope I'm answering your question there, but I think the main issue with major stimulant users is, one, the use of the drug is directly related to quite a bit of impulsive behavior. I've actually been really surprised how active they are. Like they get up early and they are out the door and they are doing things. It can be difficult for them to come to appointments because the drug is as indicated by the name, stimulating their nervous system. But the other issue is that long-term use of major stimulants really disrupts cognitive behavioral control. So, it seems like the limbic system is calling most of the shots, and that can be really hard to come to appointments time and again. That would be my guess as to why there's such a high rate of dropout with this population. The same reason why you have a very high association with criminal justice involvement and risky sexual behavior and like violent behavior and just a range of impulsive behavior. Did I get at your question? I'm not sure I did. Yes, and there's that's a good point. And there's definitely other stuff at play. We just require they don't meet criteria for a diagnosis, and our participants haven't, but there's clearly for people like a history of adverse childhood experiences that would not be called trauma, but they've clearly had really difficult childhoods. Or some of the few women who've been in the study have a history of sexual trauma, but they don't meet criteria for PTSD. Or there's absolutely affective disturbance or difficulty with emotional regulation, but none of that meets criteria for these diagnoses, which means that most of these people are probably sub-threshold. Like they definitely have some stuff going on. It's not just quite enough severe to meet criteria for a diagnosis. And it is complicated for sure. It's not just that everything's fine and everything has been fine. I'm just addicted to the drug. There's a lot more at play. And we see them for a relatively short amount of time to try to address some of that as best we can. And I think maybe where you might go from this too is, do people have any experiences where they think back to these traumatic events and reframe them in some way or experience post-traumatic growth? Were you going there? Perhaps, yes, no? Okay. Oh, yeah. Yeah, and I don't know that we've had anybody who's at least reported ADHD or would appear obviously to have ADHD symptoms. It'd be probably pretty hard to distinguish someone with ADHD from someone who's actively using a major stimulant. But that would be a really interesting thing to do.
Yeah, so
I think access to personality disorders are so difficult to diagnose reliably that we don't do any kind of formal assessment. And I mean, I could say anecdotally, I don't think we've had anybody who very clearly had an access to disorder. I think if we had someone who was, say, borderline, they probably wouldn't make it through the study. They probably weed themselves out in a sense, but we don't do any kind of formal assessment just because we know that those diagnoses are so unreliable. So unless they come in and say, I've been diagnosed with borderline personality disorder, we move forward. Yes.
the magnetic resonance imaging, was it structural or functional? And are you looking for anything in particular?
Great question. So we're doing both structural and functional. The functional imaging is focused on default mode network functional connectivity, right? So the broad question is there a change in connectivity from pre to post? And could that change in connectivity predict therapeutic response?
Resting state?
Resting state, yes. The structural is focused on MRS. I'm sorry, GLX. It is MRS. Are you familiar with GLX?
No.
Yeah. Well, in short, it could be seen as an indicator of neuroplasticity. That's one way of interpreting. It's a marker of glutamate activity, and there's some idea that if there is neuroplasticity, that's mediated by glutamate in the brain. So we're looking at GLX in a particular part of the brain to see if there's some evidence of plasticity associated with the experience.
Which part?
What's that?
Which part?
Great question. I think in the nucleus accumbens, yes. And I think we might be looking at the anterior cingulate cortex as well. Yeah, so those two regions. I was kind of hoping somebody wouldn't ask me today because I was like, oh, I don't remember at the moment. You got me.
Thank you for a wonderful talk. Two very brief questions about the pilot study. First one is, you're only using one psychedelic session,
Just
right?
one.
Yeah, and you're not adding anything after that, no?
Nothing pharmacological.
Right.
But there is more counseling.
Yeah, sure. The second question is the challenging experiences. You show the means, and I wondered about individual ratings. Do you have anyone with really high scores on fear, for example?
So that's a great question. So I don't have the data, but I can tell you anecdotally that it seems maybe a third of the participants, usually in the first hour, ask to leave. Even though we prepare them, I even tell them sometimes, you might ask to leave, but you can't leave. This is the safest place for you to be. I don't want you to leave. You might want to leave. Here's the reason why. You probably think if you leave, you can end the experience. If you go home, you're safe there, the experience ends. But we cannot bring the experience to an end. So you will stay where you are, where you're safe. And I'll remind them that because I've grown accustomed to people asking to leave. It happens frequently, maybe half the time. Even when I prepare them for that, they might in the first hour say, hey, I don't want to do this. I don't want to do it. Never mind. I want to go home. I want to go home. Call my friend, tell him to come get me now. Like, thanks. I don't want to do this anymore. Time to go home. And I'll remind them again what we've said. I think that first hour or so can be very challenging. Not only do people ask to go home, we've had people, at least one participant have something of a panic attack. She was just very, very frightened. And she even said afterwards, interestingly, that the fear was therapeutic to her. Like that she felt like she had a baptism by fire. That it was so hard, but she made it through. And that captured for her that experience of becoming clean, or there was like a sobriety experience, which was marked by all that difficulty. And she reported for the rest of her time, never using again. And she said the big reason was she realized if I use again, I'll have to go through that experience once more. And I never want that to happen again. So I'm staying clean, which is a really interesting way of interpreting it. But she had a very difficult time where she was crying, and these were more, tears of fear and distress than they were catharsis. And at one point couldn't breathe out of her nose because her nose was running. And she told me, I can't breathe, I can't breathe. And I said, you can, you just need to breathe out of your mouth because your nose is congested, right? So there as the guide, I'm just trying to stay really calm for them. And sometimes I think of myself as like a flight attendant. If you've been on a flight and the turbulence is bad, and if you look at the flight attendant and they're looking around, you might think, oh man, we're in trouble. So if they're feeling very panicked and they look at me, I try to stay really cool and say, everything's fine. Everything's good. We'll be just fine. Just breathe out of your mouth. So we certainly had someone who got so upset that she was crying and congested, and then at one point even vomited a little bit because she was so upset. I think it was a psychogenic response. So we have had people have these really intense experiences. I think they're time limited though. Like they don't last long. And one reason is, look, you can only be in a state of anxiety for so long before you just habituate, and then the remainder of the experience is, wow. It's joy and wonder and amazement. And I've sat there and listened to people say for hours, thank you, God. Thank you, Jesus. Praise God. Praise Jesus. And then the tears of joy come. So at the end, when we asked them to complete the scale, they're like, it wasn't too bad. Because it was maybe 30 minutes of terror and then 4 hours of joy. So we probably have to think about how we can capture those experiences a little better than with the questionnaire that asks them to sort of sum their entire experience. But I don't have any question that a number of people have had very intense reactions that are characterized by fear and panic. And before every session, I can tell you, like, I am on my toes. I feel kind of nervous because I know people can really react intensely. And anybody, preparing to do this work, I will tell them, like, you need to take that process really seriously because people can really, really struggle. And it's an intense experience that is not captured well by this questionnaire at all. I'm happy to answer more questions. I'm don't have anywhere to go. Whatever you want. Oh, I may not entirely understand, but are you saying that are they coming to participate because they've hit rock bottom and they no? Oh, yeah. Okay, so it's yes, that is so interesting you say that. So Humphrey Osmond early on thought LSD produced rock bottom experiences in the parlance of AA. Right? He thought that's what's happening. People have these terrifying experiences that scare them out of the drug use, but over time he realized that's generally not really what's happening because people have also these beautiful transformative experiences. The thing I'm seeing though is that the subjective experiences can vary quite a bit. And for all the talk that there's been of transformative, beautiful experiences, there's also a lot to be said for these challenging experiences. And that one participant I mentioned who would just say, I hated every minute of it. It was awful. It was terrifying. I hated it. I would never do it again. But somehow that's what motivated me to stop. And I do think there's something to this rock bottom idea. And I don't really know why it is. Sometimes people have beautiful transcendent experiences, but then sometimes it's just awful rock bottom, but still seems to work either way. So I definitely think there's something to that. I think more often than not, people have experiences where they feel the language that's been used with my participants is God has shown them how low and dark things have become for them. And that's really difficult to see. And then God brings them out of that darkness and into light and rejoice, and they're so grateful. So part of their experience is feeling like I was taken to that really dark place and then brought out of it. So that notion of rock bottom, I think there's something to that. And I'll just share one more thing. I know you want to end, but there was one participant, a woman, who told us, and this speaks to your point too, not ADHD, but told us when she was young, she was sexually abused by a family member, and during her psilocybin experience, she said that she saw her life beginning, middle, and current, like a frieze. You know what that is? Like if you go to a Greek or Roman temple, there's a story that's told there, and it's often, you know, beginning, middle, end here, and you can see it all at once. And she said she could see her life like that. And she was able to see where she is now and sort of follow the story backwards to that moment where she was abused by her uncle, I think it was. And she said that she went back to that young version of herself, that she encountered that young version of herself and said, this wasn't your fault. You don't need to go down this path, which is the path of addiction. You can take another path where you don't blame yourself, where you forgive yourself for what happened, and you know it wasn't your fault. And she felt like in that moment, she was able to get this young version of herself to take a new path and to put her where she is now, which is now someone who doesn't use. But part of that experience required that she encounter a really dark and difficult thing from her past. And she even said that, part of this was really difficult because God showed me how dark things had become for me. So I think there's something there. And the questionnaires that we use now to capture what's going on are pretty crude. And they just get it like a really broad brushstroke of what's happening. And I think it would be a great idea for someone like you to look into this like rock bottom idea.
Okay, if it's very short.
No, so I was wondering, during these trials, do you have like if something goes wrong, do you have an antidote? And how, if not, would you want to use it or?
We do have a contingency plan, and there are really two medications that are on hand. So if someone has a hypertensive crisis, their blood pressure gets too high, we would administer nitroglycerin sublingually. We've never had to do that. Now, my friend Brian Anderson in that study with HIV, gay identified men with demoralization, had one person who did experience a hypertensive crisis, but he was also paranoid and refused to take the nitroglycerin, and the blood pressure returned to normal on its own. So I think the blood pressure spikes are almost always like psychogenic, meaning they're in relation to the anxiety and the panic that people feel. The other rescue medication would be a benzodiazepine in the event that someone is really just struggling and anxious and panicking and not getting better. We haven't had to do that yet because, like I said, usually someone can only maintain that level of arousal for so long before they habituate. But we would do that if we felt somebody was really struggling and needed some relief. We've never had to intervene in either case. I don't know that anybody has yet. The only emergency situation I know of is that one that happened at UCSF with blood pressure.
But would this be a part of the business plan? I mean,
I think so. Yeah, I think if somebody was really, really anxious and it was just going on and on and on, that somebody would administer a benzodiazepine to help them calm down, or if somebody was showing just a sort of a response in which they are just almost like a psychotic type response, they clearly wasn't beneficial and they were confused and bewildered, and that really stretched on for a period of time, I think an antipsychotic might be indicated. But as far as I know, no one's quite done that, but we're selecting our participants very carefully. So I think in the real world that'll be the sort of thing that Walter and other physicians will have to figure out. Yeah, I know that will rapidly reverse the effects, but it's just not part of the pharmacy chest where we could just have it on hand. I've thought about that too. Like, why couldn't we just administer that drug and reverse the effects like that? It's just, I guess, not on the market. I know Gustav wants to end things. I don't want to answer questions if we're not allowed to.
If you have any more questions, you can just stick around and we can chat up by the podium. But I think for those who have to leave, we can end it there. So thank you all so much for coming. It's been a really great lecture. Thank you so much, Peter. It was amazing to listen to you and great to have you here. Thank you. If you want to chat,